Yes, so it's my great honor to be with you and to present my topic of presentation of surgical approaches to low-grade lumbar spondylolisthesis. The definition of lumbar spinal, is it okay? No? The definition of lumbar spinal instability was hard to be universally accepted due to its different meaning to clinicians, radiologists, and bioengineers. And most acceptable one was proposed relying on biomechanics. So instability is defined as a loss of motion segment stiffness, such that force application to the motion segment produces abnormally great motion compared to that normal spine. In other words, instability can be defined as a response to applied loads characterized kinematically by abnormal movement in the motion segment beyond normal constraints. Abnormal movement occurs when there is a damage to the restraining structures, such as facet joints, discs, ligaments, and muscles. When there is a severe damage, such as facet joint osteoarthritis, it may allow hypermobility of the facet joint, which leads to spondylolisthesis. Degenerative lumbar spondylolisthesis happens due to degenerative changes in the vertebral segmental structure, resulting in the displacement of one vertebral body over another and spinal stenosis. The diagnosis of vertebral instability is commonly based on the imaging finding of abnormal vertebral motions. There may be abnormal translation and rotation around the axis, the three-dimensional coordinate system as shown on picture. MR imaging is generally considered to be the most accurate imaging method for diagnosing the degenerative abnormalities of the spine. However, flexion, extension, lateral views of functional radiography allows measurement of the sagittal translation of vertebra with respect to the underlying one and the amount of vertebral rotation to sagittal plane. The cutoff between normal and abnormal movement on the radiography is also difficult to determine because a large range of normal motion has been reported with a substantial overlap of symptomatic and asymptomatic motion patterns. However, values of 10 degrees for sagittal rotation and 4 millimeters for sagittal translation are typically used to define instability of the spinal segment. Assessment of severity of displacement of vertebral bodies is made using Meyerding classification, determined by measuring the degree of slip using standing, neutral, lateral radiographs of the lumbar spine. Grade 1 is generally considered the low-grade slip, whereas the grades 2, 3, 4, and 5 are considered the high-grade slip. Surgical treatment may involve a decompression alone or decompression in combination with fusion procedure. In our clinic, we choose to perform decompression without fusion. The method of choice is posterior decompression that preserves middle structures of supraspinous and interspinous ligament complex, like a bilateral, ipsilateral, or over-the-top decompression. And if we decide to decompress with the instrumented fusion, middle structures may be not preserved. So whether patients require a fusion in addition to decompression remains controversial question, especially in a low-grade spondylolisthesis. So in the past years, many scientific papers were published trying to find the proper answer whether the decompression only is sufficient for the treatment of low-grade spondylolisthesis, and if so, trying to determine the criteria of the patient undergoing procedure. Also, authors try to compare decompression only and decompression with fusion techniques. In a meta-analysis study conducted by Haifeng in 2017, relevant randomized control trials and comparative observational studies were selected. And this meta-analysis included 17 studies. This analysis showed that satisfaction rate was higher after fusion procedure, and there was no statistical difference in ODI score or Weiss-Senner's pain score between groups. Overall complication rate, including rates of dural tear, infection, and residual recurrent pain, was no statistically significant between groups. There was no significant difference in the operation rate, and this meta-analysis also implied that there was significantly less blood loss and less operative time and hospital stay in the compression-only group. The second analysis this year, in the New England Journal of Medicine, published the results of the North End multi-center randomized open-label trial. And respecting the inclusion and exclusion criteria, the study randomized 2,067 patients. Results shows that surgery with decompression was non-inferior to surgery with decompression and instrumented fusion with respect to the percentage of patients who had a reduction at least 30% in the OD score at 2 years after surgery. Results for secondary outcomes with respect to pain, disability, symptom severity, functional status, and the satisfaction with treatment were generally in the same direction. The mean duration of surgery was less in the compression alone group. The hospital stay was shorter in the compression alone group. And during 2-year follow-up period, the operation was performed in 12.5% of patients in the decompression group and 9.5 in the fusion, 9.1 in the fusion group, and overall complication rate was not significantly different between these two groups. So in this multi-center single country randomized trial involving patients with dangerous single level lumbar spondylolisthesis, the compression alone was non-inferior to the compression with instrumented fusion at 2 years follow-up. Clinic for Neurosurgery in the University Clinical Center of Vojvodina is a reference institution for patients from Autonomous Province of Vojvodina. And spinal pathology is frequent in our clinic with a number of patients suffering from back pain and sciatica due to spinal stenosis and lumbar spinal instability with spondylolisthesis. So for spinal stenosis, we use 3 decompression techniques: bilateral or ipsilateral laminotomy and over-the-top decompression, but also laminectomy with spinous process osteotomy, tending to use more minimal invasion technique in regard to patients' characteristics. In cases where spinal stenosis is accompanied with spondylolisthesis and instability, decompression is usually followed by fusion, but options for treatment can differ based on the grade of spondylolisthesis and patient risk factors. Mentioned risk factors include patient's age, clinical status, comorbidities, or bone mineralization. So I would like to present to you 2 short case reports of a patient treated in our clinic for the spinal stenosis with instability and low-grade spondylolisthesis by using one of the 2 previously mentioned techniques. First case is a female patient, 57 years old, complaining of difficulties with walking due to weakness of lower extremities and sense of tingling in the both hamstrings. She had been operated 3 years ago in our clinic due to spinal stenosis in L5, L4 level. And the neurological assessment has shown lower paraparesis, neurogenic claudication, and hypoesthesia, and L4 and L5 dermatomes. MRI has shown a spinal stenosis of L3, L4 level, and the spondylolisthesis, and both levels, and L3, L4, and L4 and L5 levels. So we opted her for the compression and fusion technique on both levels, and post-operative outcome was satisfactory with patient feeling better and having good functional outcome. The second patient is a male patient, 64 years old, complaining on pain in the lower back and both legs with shortened walking perimeter less than 100 meters due to deep weakness in both legs, notifying that he had weakness in the right foot from many years before. Patient had diabetes mellitus and hypertension in medical history, and neurological assessment shown the deep lower paraparesis with peroneal paresis on the right leg from before. And we can see the spinal stenosis at the L4, L3, L5 level with low-grade spondylolisthesis. So based on neurological state and comorbidities, we decided to do over-the-top decompression without fusion. And initially, post-operative patient was feeling better with no back pain and less pain in both legs. After the physical treatment, the paraparesis was in regression. So at the end, I would like to conclude the presentation with some take-home messages that the compression alone surgery is shown to be non-inferior to fusion with the compression in treatment of low-grade spondylolisthesis, even if there were sinospinal instability on the radiograph images, and the compression techniques which preserve central stability, complex of vertebra, middle supraspinous, interspinous ligaments, helps preventing degeneration of vertebral arches and facet joints. So posterior decompression techniques which preserve middle structures of ligament complex, bilateral, ipsilateral, or over-the-top decompression provides efficient decompression of spinal canal and relaxation of neural elements. Based on all published research and personal experience, fusion after decompression is not mandatory and should not be encouraged in all cases of spinal stenosis accompanied by the low-grade degenerative spondylolisthesis. So I would like to invite you all to the ANS 2022 Congress in Belgrade, hopefully, and to thank for your attention. Thank you.